All right, so good evening, everybody. Welcome to this fourth episode of the iJournal Club brought to you by ESCRS. And I'd like to, first of all, introduce myself. My name's Imran Yusuf. I'm an ophthalmology resident in Oxford and also DPhil candidate. And I'm delighted to introduce my co-host this evening, Dr. Artemis Matsou, who is a Corneal Fellow in London at East Grinstead Hospital. So thank you, Artemis, for joining us this evening.
Thank you, Matt. And I would like to take the opportunity to introduce our great faculty for this evening. So we have two very distinguished ophthalmologists with us today and experts in their field. So we have Professor Beatrice Cochener-Lamard, who is a professor of ophthalmology and chairman at the University Hospital of Brest in France, and also past president of the ESCRS. And also we have Dr. Vasilios Diakonis, who is a cataract, corneal, and refractive specialist at the Eye Institute of West Florida in the US. Thank you both very much for being with us tonight, and we look forward to your views on this paper, as well as to you sharing your expert opinion on this.
Thank you very much, Artemis. So as you mentioned, we're going to be discussing this particular paper, comparison of femtosecond laser-assisted cataract surgery and conventional cataract surgery, meta-analysis and systematic review. And just some housekeeping for everybody today, just to let you know, if you haven't joined us before, all the participants, apart from the panelists and the host, will be muted, but we do encourage interaction, so there's a Q&A button at the bottom. Please do ask questions, and we'll present as many of them to the faculty as we can this evening. There are some interactive polls, one of which is coming soon. And you can find a recording of today's iJournal Club along with the rest of the previous episodes on the ESCRS Facebook page and on the YouTube channel. So before we get started with this study, we just want to run a little poll. So I'm going to hand over to Artemis to run that.
Yeah, so we have a few questions for our audience just to get a sense of your views on our topic today. So can we have the first question, please? So question number one, do you believe that femtosecond laser-assisted cataract surgery has benefits over conventional cataract surgery in terms of clinically significant outcome measures? Yes, no, or not sure? We've got a few seconds to answer. Okay, so 45% think that there are no clinically significant outcome measures. Good. Let's go to the second question, please. Do you perform femtosecond laser-assisted cataract extraction? Yes or no? So the majority is not performing FLAC surgery. Thank you. And third question. Would you prefer to be trained in FLAC surgery if you had the option early or later in your residency training? So first option is early. I would prefer to start training with critical steps already done by the laser. Or late, I would prefer to be proficient in conventional cataract before trying this technology. So 70% would like to be proficient in conventional cataract before trying this, okay? And last question. Do you read the supplementary material in research papers? Always, usually, rarely, or never?
Remember, this is completely anonymous, so you can say that.
Just speak freely, yeah. Okay, so the majority is usually, followed by always and rarely in the same percentage. Okay, thank you. So I will pass you over back to my colleague Imran.
Thank you very much. That was interesting to run that poll. Okay, so what I'd like to do now is just briefly go over the paper. Some of you obviously would have read it before, but it's such an important subject that I think it's important to go over the data very carefully. So we're going to do that together now. So, of course, you'll know that meta-analyses and randomized controlled trials sit at the top of this pyramid of evidence hierarchy, we call it. So clearly, the risk of bias is typically lower with meta-analyses and randomized trials, and the quality of evidence is higher. So, of course, with such an important question in ophthalmology, this is, of course, an important study. So it's good that we're discussing it. I find it quite useful before reading a paper just to go over, obviously, the abstract and also what the paper feels as though it's added to the current literature. And so reading the box that's presented in this particular paper, they state in what the paper adds, they say that both procedures are effective and safe, that complications occur rarely. They say that visual acuity at the medium-term follow-up is slightly better after femto laser. And they also mention at the end that femto laser is beneficial in the short term for patients with low endothelial cell density and dense cataract. So that's what the paper says. And having read the abstract, I realized there's a conflict there because the abstract actually says in the conclusions that, however, midterm visual acuity did not show any difference between the methods. And that's obviously in conflict with what they've said in that box where they say that the flax is slightly better. So anyway, just something I noticed. Of course, with meta-analyses and systematic reviews, it's important that there are very clear criteria so that the study can be replicated, and the study makes it quite clear how they included the study. So they searched these 3 different databases, PubMed, Cochrane Library, and Embase, and they use the following search terms which they produced there to find the femto laser surgery studies. One of the reasons they did the study was they wanted to include both prospective and retrospective studies that aim to compare both. They decided to include publications in English only, so they excluded papers written in any other language. One thing they did to make sure they included all studies was to reference check to ensure that the references of the studies they did include were checked for other relevant studies. And this was done by 2 authors independently. So what did they look for? Well, the outcome measures they looked for were unaided distance visual acuity at 1 week, 1 month, 3 months, and 6 months. The same with corrected distance visual acuity. They looked at spherical equivalent outcomes at the same time points again. They looked at mean absolute refractive prediction error at the same time points. They looked at surgically induced astigmatism. They looked at surgical endpoints as well, so total phaco time, effective phaco time, cumulative dissipated energy, and the circularity of the capsulotomy. And they looked at safety, in particular anterior and posterior capsular ruptures, whether there's an elevated IOP early following surgery, the occurrence of cystoid macular edema 3-6 weeks and at 6 months, central corneal thickness, and endothelial cell loss. So in particular, the reason why I want to go through the study is that most of the figures aren't really within the main body of the paper, and that's why we asked you about supplementary figures and whether you go through them. And I think you really need to look at the supplements to understand this particular study. Just to mention also, they excluded resident-performed femto and femto undertaken during what they consider the learning curve, and they talk about that in the discussion. They talk obviously about how they analyze the data, how they assess heterogeneity, in other words, how similar are the results between studies within a given parameter. And at the bottom there, they also used established tools to grade the bias for both the randomized trials and the cohort studies. So what did they find? So they found 5,600 studies, and they removed the studies which did not meet the inclusion criteria, leaving 73. And this included 12,000 eyes which underwent femto, and slightly fewer which underwent conventional cataract surgery. Of the included studies, there were 25 randomized trials and 48 comparative cohort studies. They varied in terms of where they were undertaken. And the laser platforms that were used varied as well, so they're listed there. So in the supplements, these are the trials. So you can read about all 73 studies, whether they're prospective, retrospective, where they originated, what laser system they used, how many eyes were included from both groups, and the follow-up. So that gives you a good idea about the number and type of study that was included. So we'll go through the outcomes. So in terms of the visual outcomes, they found no difference in unaided distance visual acuity at 1 week. You can see the relevant plot in figure A at the top there. And you can see that at 1 week, there's no difference. At 1 to 3 months, there is a slight difference, which is just statistically significant in the middle panel here. But that was lost at 6 months. So that's unaided distance visual acuity. And for corrected distance visual acuity, the findings were really quite similar. in that there seemed to be an effect at 1 to 3 months, but that was lost at 6 months. And what they also mention quite prominently in the paper is that at the medium term, which they class as 1 to 3 months, there did seem to be an advantage in the femto group versus the conventional group in terms of the unaided distance acuity, corrected distance visual acuity, and also the spherical equivalent. So that's obviously something we'll talk about. They found that the mean absolute error was superior in the femto group at 1 week, but no difference was found at the later time points. You see, at 6 months, there's no difference here statistically. And, the astigmatism, they found there was no difference overall between the groups. And you can see that summary plot down here. They also decided to do a subgroup analysis of only the randomized trials. And you know there's about 25 of them included in this study. Interestingly, they don't produce the plots for this particular set of data. They just show a table in the supplements. But they find that once, when the randomized trials only are considered, they found that femto laser was superior in terms of unaided distance visual acuity at 6 months or more, corrected distance visual acuity at 1 week and 6 months. The mean absolute prediction error was better throughout, as was the spherical equivalent. So I was hoping to see the plots of this, but they don't show the plots. They show this table in which the different groups, the different categories or parameters are looked at individually, but it's not really stated what studies were grouped in those particular analyses. So within this table, you can see these boxes initially summarize the data I've already shown you. They also show that some of the phaco time outcomes were obviously less in the laser group compared to the conventional group. Circularity was less in the femto group. And the capsular ruptures were none of them were statistically significant when only the randomized trials were looked at. Cystoid macular edema appeared to be no different within these particular studies, but there was a difference in terms of central corneal thickness, which was lost at 6 months. And there was also a difference in endothelial cell loss, which again was an effect which wore off at 6 months. So this is a sort of a subgroup analysis of only the randomized trials. What about the surgical endpoints? Well, they looked at total phaco time, and they found that femto had a shorter total phaco time, and that's quite significant. You can see in this plot up here. And the effective phaco time overall was also in favor of femto laser, but this was not the case for all laser systems. You see these two laser systems show no difference, for example. Cumulative dissipated energy was also lower in the femto group. You can see that here, that's the overall plot. And the circularity of the capsular axis, which of course you'd expect to be better in the laser group, was found to be better in the laser group. And that was obviously true of all studies here. Interestingly, part of this particular analysis is to look at heterogeneity. That's how similar the results are between studies. And for example, you can see in this particular study, the heterogeneity was found to be sort of quite high. Mostly because the effect size seemed to vary quite a lot. So heterogeneity is something important to look at in any meta-analysis plot so that you can work out how statistically similar the results seem to be for that parameter. Obviously, a very important thing is intraoperative complications. They found that anterior capsular tears were more common in femto laser, 0.97% versus 0.2%, that was significant. And posterior capsular ruptures, however, were not found to be different between the two groups, although they were slightly higher in the femto group. They included this particular sentence, which wasn't very clear which way it was leaning, so that's why I just put the screenshot in there. And I'll show you the plots from which these summary data are derived. So on the left, you have anterior capsular rupture, and you can see that overall, there's this particular parameter is in favor of the conventional surgery. In other words, there were fewer events in the conventional group. You can see overall, there were only 16 events in the conventional phaco group and 78 in the femto group. And so that's quite significant. In particular, these studies up here probably slightly skew the analysis because they had quite high occurrences of anterior capsular tears in the femto group. For posterior capsular rupture, you can see overall there's no difference between the two modalities. And we looked at the different laser systems individually. I suppose overall there was a difference in the catalyst group where 20 events happened in the femto versus 8 in the phaco. But overall they found no difference. Postoperative complications, they found there was no difference in IOP spikes between the laser treatments, and cystoid macular edema, again, no difference between the femto and conventional surgery. Corneal properties, so all of these different measures seem to go along the same theme, really. So corneal edema at 1 month and 6 months, there was no difference between the two groups. You can see the percentages here, and the plot overall, you can see that crosses the line of no difference. But the study did find a higher central corneal thickness at 1 day and 1 to 3 months in the conventional group, but that difference had worn off by 6 months. So you can see that generally over time that sort of effect wears off. Endothelial cell loss, they also report the same thing, but the plot for that particular parameter is not in the paper for some reason. And lastly, they did overall look at bias. So it's important in a meta-analysis to look at bias, and these different categories of bias. There was some judgment about whether the risk was high, whether it was unclear, or whether it was low. And I suppose in general, the key things to look at here are performance bias, which was thought to be quite a high risk in the study overall, mostly because you can't blind the participants or the personnel to what procedure they're having done, or not very easily. Same for the outcome assessments too. And lastly, they did systematically look at the quality of the studies. This is a table in the supplements where they grade the quality of the observational trials on a 9-star scoring system. And they found that only really one trial had a low score, and this was the study up here. So that's enough for me from now, but I did think it was important that we went through all of that data so that now when we discuss it, you know what we're all referring to. So I'll hand over to you, Artemis, to start our questions.
Thank you. So we have a very interesting paper to discuss today, and I think our faculty have both the academic and clinical expertise to help us analyze this paper. So we have a combination of questions on the critical appraisal and also on the wider relevance of this paper on our clinical practice. So first question, and I would like to start with Prof. Cochener-Lamard. So the authors have done a very thorough literature search and a careful selection of studies. However, the majority are indeed observational studies. So that's 86% of the included studies. And only 14% are randomized controlled trials. And also they mentioned that in one of the, as a possible limitation of their study. Do you agree with the study design? Do you think it may have influenced the interpretation of the results due to the increased risk of biases that observational studies have? And is this how you would have set up the study if you were conducting it?
I think that, you know, the beauty of these studies, first of all, to try to do the best they can. So I think that, first of all, we noticed that there are a lot of papers published on that topic of poor quality, I would say. We can even add that some of them were influenced by some conflict of interest, because when we first started with some of the studies, they were driven by some specific platform. So that's one of the key limitations, but I think that the way they have managed the study is perfectly clear. And introducing some retrospective and observational study to the randomized clinical trials were very well done, I would say. So of course, you can't get more that you can expect from a meta-analysis with so poor homogeneity between all the different trials. But I think that what they did was, first of all, to provide us a very nice list of the key limitations that they had. And I think that, I mean, that's the beauty of the analysis that they provided. All the key limitations that they emphasized are completely aligned to some great work that have been conducted since that time. And of course, I cannot resist to the temptation to mention to you one of the, I would say, leading papers in this area, which is the French randomized double mask study conducted under the sponsorship of our Ministry of Health in France, that ended up with a publication in the Lancet this year in January 2020. And what is good, actually, the conclusions are exactly the same, but it was a very well-designed study. So that was actually a study with 2 endpoints. One was the refractive outcome, so the clinical outcome, and the other endpoint was focused on the cost effectiveness. So in top of that, looking at the results of the meta-analysis that you are presenting tonight, we also provided a nice demonstration of a terrible increase in terms of cost that is not justified. I mean, if you do emphasize what you did tonight, no significant differences between the two strategies. So, I mean, there is nothing nowadays that justifies extra cost. And if I may add just a few, I mean, something that to me, it's quite important when we do mention the comparison between so-called femtocataract surgery and phaco. I mean, we shouldn't mention that it's a pure comparison when we think that femtocataract surgery is just an enhancement of regular phaco, because you're still using ultrasound. You're not dealing with a complete new platform. So, I mean, it's not really a comparison of two different techniques. One is only the enhancement of the other one, the previous one.
Excellent, thank you very much for that. And thanks for mentioning the other study that hasn't been included. So Vasilios, I just wanted your opinion on some further potential sources of bias and error in this study. So the authors state that they excluded studies reporting results of first cases of LACs and surgical results from resident surgeons. However, the seniority of surgeon for conventional cataract surgery, I'm not sure if that has been taken into account. Do you think that this adds bias on the reported outcomes in favor of LACs?
This is very, very important. For a good surgery to be good, it has to be done and be available to be done by everybody at the same level. So if you look at the papers that you've seen, and especially at the very beginning of LACs, the companies were very careful to whom they were giving the platforms and who was using them and who was actually publishing, because they didn't want to kill their technology. So if you look at the papers, you're talking about super surgeons. You're talking about like the Ivy League places in the world, university hospitals, like super private hospitals that can afford this technology. And the surgeons that were performing the surgeries were very, very good. So if you compare a super surgeon to the femto, most likely you will say that it's about the same. If you include residents, most likely you will see that the repeatability and the safety of the procedure would be probably better when you do the plaque. So that is a problem. There's not enough studies out there to support that. But if you look at the names and the authorship and who does the surgeries, maybe you will understand that super surgeons are doing these surgeries, not like the residents and fellows.
Good. Yeah.
Vasilios, wouldn't that apply to both groups? So, for example, if you did have super surgeons in the Ivy League university hospitals in the US, like you are, wouldn't they be doing both femto and the conventional cases? They
would try to teach conventional surgery first. And if you see the included patients, who is the surgeon, most likely is not the residents or the fellows, most likely is like the attendings who were trying to use the technology, and the companies were supporting them to do so.
If I may add also something, I mean, regarding the platforms, I must say that we should really make a difference between the first generation of femto laser platforms and the one who are now available in the market, because I mean, they've made so huge progresses, especially in the management of the incision. And it's all about, the imaging system that is guiding the procedure. So, I mean, that's one of the key issue. And the second one, we made a pilot approach comparing the management of femtocataract surgery done by fellows compared to seniors. And we were quite surprised to see the juniors doing not as bad as the seniors, because there is a learning curve for both. And I must say it's all about computerization. So I mean, I would say that if you are familiar to simulator and this kind of imaging guidance strategy, you may even shorten your learning curve, whatever you are, juniors or seniors. And don't forget that in the meta-analysis, there is one, I think to me, important point that they made. The complications, they don't occur during the femto cataract step, but it's only during the phaco. So it's all about, again, the difference between junior and senior that happen here.
Excellent. You have already answered my next question, which was whether the inclusion of different laser platforms adds bias, and you agree with that, as I understand. Excellent. And next question is for both of you, really. So obviously we're aware that femtosecond cataract surgery is usually done for non-monofocal IOL, so toric and premium lenses. However, there was lack of reporting on the type of IOL used in most of these studies. Would it be more useful to know this piece of information? And would it be more useful to run a trial comparing FLACS versus conventional cataract surgery for monofocal IOL implantation, as this could be more relevant to our practice? Professor?
Yeah, I mean, if I may answer on that, you know, I would take maybe a funny example of comparing two cars. If you ask a car to have a speed limitation of 20 km per hour, whatever the car you can use, both will be competitive. But if you make a difference that will be tiny, like comparing a very fine premium lens with a very complicated optic to a regular monofocal, it's where the difference should be observed. But unfortunately, we don't have so many well-randomized trial conducted with this kind of, I would say, sophisticated optics. So that's why it's difficult to make a difference there. Unfortunately, I would say, because if we could wait a very, I would say, nicer performance with such a femtocataract surgery that offer you a good centration, a perfect rhexis, in this area that should emphasize a difference. Even if we know that it's not because you are performing a very well-centered rhexis that they will guarantee you a perfect centration of the IOL, or even, I would say, an effective positioning of this lens perfectly well controlled. So we don't have the answer, I would say, unfortunately, in that regard, but definitely for toric IOL, or diffractive, multifocal IOL, it's where we should expect potentially a difference.
Excellent. And Vasilios, anything you'd like to add on that?
Sure. You have to also consider one simple thing. A meta-analysis takes and analyzes studies that exist, which if we consider the authors like them and us who are producing these papers, we have produced the papers that are out there that they analyze. So we have not come up yet with probably the necessary information, and nobody has sat down to conduct all these hard and lengthy studies. I mean, the French study went all the way to the Lancet journal because it was randomized, double-blind. These are not easy studies to do, and nobody really undertakes all this weight to do it. But we have to be happy because 25 of them were RCTs. In the past, it was very hard to see an RCT study, even for refractive surgery, which was a very hot topic. So it's a new thing in our world. Femto and 25 RCTs up to now, I would say that I'm quite happy with the data that we have.
Excellent, that's good. Now, what about their reported complications with FLACS surgery? So it seems that anterior capsular rupture was significantly more common in the FLACS group compared to the conventional cataract surgery group, despite the fact that they may or may not have had more senior surgeons doing that. And the PC rupture rate was not significantly higher, and neither were other postoperative complications like cystoid macular edema and high LP. So that would probably mean that conventional cataract surgery has a more favorable complication profile over FLACS. How do you think?
Can I make a comment about that first, Professor?
Yeah, sure.
And I will ask you, I can ask you that question. Who does your FLACS in your center? Is it you or is it your fellow? Or
no, it's myself.
It's yourself.
Yeah.
So this is not the case in every practice. Somebody else does the FLACS and somebody else does the surgery. And that can create a problem, especially with the anterior capsular extension. You have to pay, this is the only probably thing that you have to pay really close attention when you do femto to see that champagne gas circular pattern to come up. And the surgeon has to be very careful when they're trying to remove the capsulotomy button from the AC, because if it's incomplete, then if you pull it out, you will get an extension. So I believe that the problem there is also who's doing the femto and who's doing the surgery. If you don't have a complete view of what's going on. And I've seen that a couple of times. So the suggestion that for the listeners that we have here today is just pay attention, because that's probably the most crucial point of femto assisted cataract, to see that nice circle and just take it easy when you try to remove the button, because you don't want to have an extension.
Yeah, I would add, I mean, what is also well identified after a femto is a sort of increase in the cytokinic reaction in the anterior chamber. So that's also clear that people, I mean, in many cases, they do increase the anti-inflammatory drug regimen after the surgery. So, I mean, it's not clearly expressed in the results, but I mean, it has been mentioned in this meta-analysis. So it's something I think that should be taken into account. As the patient flow, I fully agree that, I mean, the management of the patient makes a huge difference. If you need to ask the patients to, I mean, to stand up and to change the room, to lay down again on another bed, that makes a huge difference in terms of, I would say, even the entire, control and management of the surgery. Definitely, yes, yeah.
Excellent.
But you know, when you think about where we are now, I mean, looking at this great meta-analysis, and again, since that time, we do have two great randomized studies that have been published. We got the answer. The penetration of the market is not there. That means that the adoption of the surgery was not as great as expected. That's why the industry, if they may still work on it, are not really reinforcing the interest of selling this kind of platform compared to the refinement they are still making on the femto machine. And I think that the future will be certainly not, I mean, we may not abandon the concept of using femto, but I mean, we need a combo machine that will provide all the different steps on one single platform. And that will certainly help us in solving many of the issues that Vasilios already pointed out. I mean, like the two big steps of one single surgery. As something is very, I mean, to me, something is really missing in all this publication, it's patient satisfactions. We did a study in France comparing the patient's feeling, getting one femto in one eye and one phaco in the other eye, on a randomized basis. So, I mean, the first eye could have been a phaco, or the second one, I mean, that was really well designed. And, you know, the duration, the patient's feelings in terms of pain was actually in favor of the phaco, regular phaco, compared to the femto. That's something that is also missing. It's such a big meta-analysis, I would say.
On patient-reported outcomes.
Yeah.
Absolutely.
The ergonomics are very important, and how you manage the patients and circulating them. So the prostaglandin release induces meiosis. If you wait too long, the pupil will go down, and then you have other issues. The best probably approach right now with the current platform is to have them in a separate room and wheel the patient in the femto and then wheel them out and take them to the OR. No other waiting nor standing up. So do the femto and you move directly to the OR.
Yeah. And you know, if I may add another comment regarding the indications, what is quite funny, I mean, it's already very well demonstrated in this meta-analysis. When we first started with the femto cataract platforms, we used to contraindicate all the different difficult situations like pseudoexfoliation, shallow eyes, pediatric cataract surgery, wide cataract. And when we think about what are nowadays the best indications for femto, it's exactly the initial contraindication who became today the best indications for femto.
Yeah, very, very interesting. And Professor, what is your view on the role of flax in residence training? Should it be incorporated? And if yes, how and when? And if yes, do you think that that will de-skill training residents on manual cataract surgery, as the most critical steps will be automated by the laser?
Yeah, you know, I still belong to this old generation of people who assume that actually the residents should be able to manage an extra cap, a regular phaco and a femcat. So the big issue is if you start and jump on a femto platform, they may not want to learn anything else. So I think that first of all, since again, most of the complications, they do happen at the phaco step, I would start with a conventional femto cataract surgery, and then of course move to the femcat, which is, I mean, quite easy for the young generation to manage. It's all about, you know, joystick with imaging guided, so it's not a big deal for the young generation.
Excellent. And Vasilios, what do you think?
I think the residents and the fellows have to go through the process of learning everything. And for me, personally, I would say that when the laser does a lot of the surgery, it's not fun for me. I mean, I'd rather use my hands a little more rather than having the laser. But again, my hands are not going to create a capsulotomy, which is going to be perfect. So at the beginning, you have to learn to do it with your hand and take care of complications. And I mean, when you reach the stage of like cataract refractive surgery that you really need to provide superb outcomes, then, you know, you have to use the technology. And of course, it depends on what kind of practice and what kind of future you're looking for yourself as a resident. If you're gonna want to go into the area of refractive cataract surgery, but if you live in Africa, for instance, I mean, cataract is a blinding condition. They don't care if they don't have to wear glasses, they care to see. So it depends where you are in the world and what you want to do.
Good. And what about the learning curve? Oh, sorry. Yeah.
No, I was going to make a joke. You can imagine the economical model of a femto cataract in Africa.
Yeah, it wouldn't work very well. And what about the learning curve for the surgeon? So it's a bit random, I think, in the literature as to how many cases make someone proficient in femtosecond cataract surgery. So that differs obviously for a novice surgeon versus an experienced surgeon. Are there any data that you are aware of? Any cutoff point after which we say someone is proficient enough to do it?
I get that everyone can take his own experience and the experience of the center. I was quite surprised to read in the article that they were mentioning something like between 100 to 400. I would say that, you know, when we first started with this randomized study, they were asking us to perform something like between 30 to 50 cases. And in my hands, I would say that regarding all the investigators that we had around the country, that was good enough. So I would assume that you get familiar with 50 cases. That will be maybe the average. Again, taking account the generation of platform that you are using, because there is a difference between one platform to the other.
Yeah, absolutely.
And I would agree with the professor here. 50 cases, more or less, it's a good number when you know how to do phaco, manual phaco. I believe that the resident and the fellow should, and of course the people who train them, they should focus on what the differences and what they should be careful for. Like how you dock the patient, if the suction is on, if they lost suction, because that can be a problem during femto, how to manage the capsulotomy in surgery, how not to aggressively do hydrodissection because there's gas entrapment and you may have a PCR. So like focus on the detail, and 50 cases I think would cut the deal.
And actually, you know, people who are familiar to manage a docking process, I mean, especially if you do have an experience with LASIK, it's certainly a little bit easier to approach, you know, the docking system, because I mean, some surgeon can be afraid of managing the suction to start with.
Absolutely. And that leads on to my next question as well.
Sorry, again.
both of you as well. So what are your tips on the little challenges that we have in flax cases? For example, how to check for a free-floating capsulotomy, how to perform a hydrodissection to avoid a capsular block, how to deal with post-laser meiosis, and cortex removal, because we know that it's more adhered in the anterior capsule after laser. So Professor, what are your tips?
Yeah, so I agree with Vasilio that you learn from your mistakes. So especially, I mean, when people start to consider that after the laser, you can manage your phaco on a regular basis. I fully agree that first, you need to avoid any hyperpressure in your eyes. So you need first to do your best to evacuate the gas that has been accumulated behind, and that would preserve you and protect the bag from any anterior capsular tears first. Then after the hydrodissection, you need for sure to manage. It depends of if you're going to use the cubes of the pattern of the cut of your nucleus So you also need to make your own experience and to decide with what you will be more familiar. But I think that first of all, you need to make sure that without using too much liquid, you will be able to detach this nucleus. Regarding the management of a posterior tears, I must say that it can become a drama very fast, because the way it happens can take you by surprise, and the extension goes very fast. So the complications, when they do happen, at least in my experience, can be more severe in the way they happen and the extension that they can take. So then after, of course, you manage the best you can, but it's not so easy, because if you are underneath the microscope, close to the laser, the way you can handle the situation under pure topical anesthesia, it's sometimes really tricky. Regarding the meiosis that can happen afterwards, I don't know if you're familiar, and I have no financial interest at all in this combination, but you've heard about the migraine, which is a combination that's put together some anesthetic drop with a very efficient way of getting the dilation with a few seconds. To me, it's a very interesting product, especially during the surgery, if you want to add some, I would say, additional effect on the dilation.
Yeah. And Vasilios, what about you? What are your tips?
Pay close attention to the screen when you do the femto, just to make sure that everything went according to plan. When you go in the surgery for the capsulotomy, I would say that the dimple down technique is very good. You go in the center of that capsulotomy button and you compress a little bit, and if you see a concentric like retract of that button, that means that it's free. Some other surgeons go in, they don't even take it out. They go in with the phaco tip and they suck it out. But if you have, if it's incomplete, then you will have definitely an extension. So don't be Superman. Try and do it slowly so you're sure. The hydrodissection has to be slow, so you don't pressurize the bag and you have a PCR. Concerning what you said, Artemis, about the cortex, at the edge of the capsulotomy, the cortex becomes opaque white, and this is because probably of heat, and it melts down together, like becoming one metal piece. So it's harder to remove. It's, so take your time, be slow, so you don't create any problems at the end. Concerning the meiosis, do it fast. I mean, don't wait. Don't make the patient wait a long time between the two surgeries. If you do it fast, most likely it's going to be okay. In the practice that I am, we always use intracameral mydriatics when we start the case, so we avoid this problem.
Good, excellent.
If I may add also, I mean, I think that one of the steps that we are missing there is the incisions. I don't know about you, Vasilios, but I mean, it's not always a guarantee that you're going to get the predicted incision that you're planning. It's really depending of the first of all of the what kind of imaging system you're using. But I mean, in case of your incision is not well located, don't even touch them. Don't try to open or manipulate, because I mean, it's going to be a disaster. We know the key value of the main entrance. So that will be even worse to try to manipulate, enlarge, damage with the too long tunnel to internal tunnel. So I think that in that case, you'd rather forget about the laser incision and go directly to the regular knives.
Professor, we have given up doing incisions with the lasers. We always do them manually. But we find great value in what the laser does concerning corneal incisions when it comes to correcting astigmatism at the level of the cornea.
Sure.
Precision is phenomenal, and especially those lasers that have the registration system with the iris, and they can compensate for cyclorotation. I mean, the axis of the correction of the astigmatism is like spot on. I don't believe any hand in the world can do such a precise cut at the precise place. So for that, we have to give some credit to the laser.
Do you have a long follow-up on that? Because I mean, I know the incision coming from the femto that we're using for cornea, but we notice with the time some regressions. So you do have a long follow-up, I mean, for the stability of these incisions?
No, You know, we don't have a long follow-up, but I believe that it will be similar to the manual A case we've seen in the past.
Would be interesting to see in the future. Yeah.
When you publish that
another
paper,
topic,
we can discuss it on this on the show.
Yeah, sure.
I suppose just because we're running out of time, one question I want to ask, I don't know whether this can be answered in a yes or no, but do you think the absolute circularity of the capsular rhexis is significant? Vasilios?
I think the size is more significant probably than the absolute circularity. So if you're talking about a tilted lens, if the capsular rhexis is too big, maybe that will be more prominent. If you can cover the lens at like 80%, then most likely you will not get it. But it looks good though. I mean, if you look at it on the next day, it looks very pretty.
Yeah, except the patients don't know.
Yeah.
Don't know yet.
Which is why I'm glad, Professor, you talked about patient-reported outcome measures, because of course we don't explain material benefits of cataract surgery in terms of circularity, in terms of how thick the cornea will be in the medium term, and how many endothelial cells are losing in the medium term. So anyway, I suppose that's a key area that this trial, this study didn't really go into in depth.
I mean, look at something else which is important. The intraoperative metrics of phaco time and all those were less. And you're talking about experienced surgeons again. So even in the hands of experienced surgeons who can do any type of chop, the phaco time and the overall time used and the energy used in the eye was less. So yeah, something is happening there, but we don't have yet the studies probably to prove it.
Yeah, okay. So let's look into the crystal ball, just because we're coming to the end of the show. In 20 years' time, will we be using femtocataract for our routine cases? Professor, what do you think?
Yeah, so I mean, I think that I already gave my opinion on that. I think that it will work only if it comes as a combo. If you got on the same platform, the way to use the femto to manage your nucleus, and at the same time, you can aspirate, the nucleus and the cortex. If we keep using these two machines, these two platforms combined, it's never going to work. And we got the answer nowadays. First of all, not only for the clinical outcome, but also for the cost effectiveness of the model.
See, that's what you think. Anything different?
I think I'm going to be a little bit more futuristic. Maybe we're going to see a world where we don't even do surgery ourselves.
Oh, yeah.
Or even giving a drop to the patient that will never develop cataract. So everybody's going to be out of business.
All right, I'm going to call you in the year 2040 and ask you whether you're still operating.
Yeah, he's going to get the Nobel Prize if he can do that for us.
All right, that's been a really lively, a really fantastic discussion. So just to finish off, we have a little poll, and I'm just going to share slides here. As Artemis, do you want to run the final poll before we?
So we have less questions this time. So we have 2 questions for our audience. Same as before, do you believe that femtosecond laser-assisted cataract surgery has benefits over conventional cataract surgery in terms of clinically significant outcome measures? Yes, no, or not sure? I just want to check whether you've changed your mind. And you haven't changed your mind, so the answer is still no. Okay. And the last question? So do you think that flax will become the predominant method of cataract removal in developed countries within the next 20 years, as Imran has already questioned our speakers? Yes, no, or not sure? Yes. So the majority of our audience believes that it will be. Great. Very interesting.
Very interesting indeed. All right. So I'd like to finish just by thanking my co-host for the evening, Artemis Matsou. Thank you very much for your input tonight. And of course, our guest panelists. It's been a fantastic, interesting, dynamic discussion. And Vasilios, Professor Cochener-Lamard, thank you so much for your time and your insights. It's been a pleasure having you on our program.
Thank you.
Thank you. Bye-bye.
And before you all go, just save the date, Wednesday, the 14th of October, we'll be talking about this paper. This is about the development of a reliable preoperative risk stratification system for phacoemulsifications. Obviously very relevant to training, and this paper proposes a new system, so this should be of great interest. So do save the date. We'll send a link round for you to register in due course. And thank you very much for joining us this evening.
Thank
See you
you.
next time.
Bye-bye.
Bye.